So thank you for joining us for our latest webinar from the Sussex Eye Group. This webinar is being recorded and will be available on our YouTube channel, hopefully when I get round to sorting it out. There is one CPD point for people who have watched live, and I will send the certificates out within 2 weeks. I'm not going to say a date when, but I've got 2 weeks to send the certificates out. There is a Q&A box at the bottom of your screen, so if you have any questions, then please type them in there, and at the end of the lecture, I will then present them to our speaker for him to answer to you. So I'd like to welcome our speaker tonight is Mr. Oliphant. He's a consultant ophthalmologist specialising in oculoplastic, lacrimal and orbital surgery at the Sussex Eye Hospital in Brighton. He runs a regional clinic for patients requiring eye removal or remedial orbital socket surgery. He is a clinic lead for the ophthalmic A&E department and is an honorary lecturer at the Brighton and Sussex Medical School. He's also a consultant at Eastbourne Eye Hospital and does 1 day a week there, so which is always good. So thank you very much, Huw. I would like to hand over to you now. So thank you very much.
Great. Cheers, Ian. Thank you very much for having me back. I'm just going to make this work a second. Right. Can you just confirm that you can see all of that? Is that all right?
I can see all of that, yes.
Okay, cool. All right. Well, yeah, thanks for having me back. It's nice to be trying to disseminate a bit more info on watery eye stuff. I realise it's not a massive problem. It's not quite on the same level as macular pathology and so on. So I realise that it may not be quite as intriguing to you, but the reason I wanted to talk about it is we get so many referrals in the NHS, and private less so, but way more in the NHS for watery eyes. And a lot of the time, nothing really needs to be done about the watery eye problem. But I think for the main part, it's just trying to demystify what we do and try and sort of make you a bit more aware of the terminology and perhaps some of the understanding of the anatomy. So I always, when I was very junior, I used to really struggle with watery eyes when I was a sort of junior surgeon. I found it confusing. I didn't really understand it, and I wasn't that interested in it, frankly. But as I understood it more, it became less of an issue, and it's quite a quick problem to kind of work out if you know what you're doing. So hopefully you learn a little bit from it. I blurred my background out this time because last time I got a bit of abuse from some people I know about my yet to be renovated house, and it's still not renovated. So I'm blurred, so you can't see what's in the background. It's just my terrible wallpaper and fittings and things. So I mocked up this GOS 18. Is that what it is? A GOS 18? I should know that. We get this so often in the into the hospitalized service. I think it's probably not people who are on this webinar. It's probably people who don't come to webinars and do get CPD and stuff. But so often we get a referral like, this patient's got a watery eye. Can you just unblock the tear ducting clinic, please? And then the patient comes in and is like, can you not just like sort of dime rod it down and just unblock it? And of course, that's basically never the case. Almost always, the patient needs a few more investigations. Then when it actually comes down to it, it might be quite a major operation with them needing an anesthetic. So I think if you can kind of improve communication in primary care, it'll make a big difference in terms of patient expectations, because we often have to try and bring patients back from that kind of thing whereby they just think they need like a little sort of quick flush out in the clinic. And it can be that sometimes, but more often than not, it's going to be something surgical or nothing at all. And when you do tend to present the surgical options to patients, if the watery eye isn't that bad, often they'll back off from it. So for me, like, expectation management is more important than anything really in clinic. Trying to get people's expectations aligned with what you can deliver is the most important thing. So just very briefly, I know you probably all know this, but just a quick run through, and I'll go through the sort of the drainage system in a bit more detail next. So the lacrimal gland's got 2 lobes. So the main lobe, the orbital lobe, sits just within the orbital rim here. It's about the size of an almond. And then there's another lobe, which is a palpebral lobe. And sometimes when you're on the slit lamp, if you just lift the lateral corner of the lid, especially if someone's got floppy lids, and these sort of men who overweight with sleep apnea, they've got very, very lax lids, and you can just lift the lid up and you can see the palpebral component. And those 2 lobes are connected by some ductules, which then exit onto the surface. And if you're ever interested, if you put a bit of fluorescein in and just invert the lid and look at the palpebral lobe, you can see all the little openings. And if you squeeze it a bit, you can see the aqueous coming out. So it's good to be aware of where those are. And some, they can be subject to lots of different, lots of different pathologies. And we sort of deal with that quite a lot more on the orbital side of things. And obviously your tears drain across the surface and they go into the puncti, upper and lower. The lower one sits about 0.5 millimeter lateral to the upper from medial canthus. And then the canalicular system has a little vertical component which goes about 1 or 2 millimeters, horizontal component, and into the lacrimal sac, and then down the duct. The duct's about a couple of centimeters long. So it's actually way more complex than that. So if you simplify it, it's all kind of hunky-dory and so on. But if you look at it in a lot more detail, there's loads of valves within the lacrimal system. And so the common sort of areas that we see issues with outflow obstruction around the puncti, so particularly the sort of lower one, because the lower takes a few more tears than the upper. So people typically quote about 60% of your tear drainage goes through the lower punctum and then about 40% by the upper. So I tend to see way more in my clinical practice people with lower punctal problems, so either punctal eversion or punctal stenosis tends to be much more of an issue on the lower than the upper. And then within the nasolacrimal duct, there's loads of valves. I think there may be between like 9 and 12 described. The commonest ones that we look at are the valve of Rosenmuller, which is where the valve between the common canaliculus and the lacrimal sac, and then also the valve of Hasner, which is at the very bottom. I don't know if anyone, I'll show you a video later on in the talk, but at the very bottom of the lacrimal sac, that opens just underneath the inferior turbinate in your nose. So if you look inside the nose and you look underneath the inferior turbinate, which you can't do without an endoscope, but if you have a look, you can see the bottom of the nasolacrimal duct. And if you ever do a syringe and probing, if you probe down the tear duct in an infant, for example, you can see the little rod coming out the bottom of the tear duct. So all of these things do play out in reality and you can see them. But I think the purpose of this slide really is just to show you it's not totally straightforward. The lacrimal system is quite complex. And if you understand that, then you can understand why sometimes it's hard to solve people's watery eyes. In reality, most of these patients have got multifactorial watering. So they may have a component of like evaporative dry, or they may have a component of over secretion, and then they may have a component of outflow obstruction. And it's just trying to tease out which is which so that you can then understand what you're going to do with the person. So I guess, is it a problem? Are watery eyes an issue? Well, I'd be curious to know if you, just in the comments, like how many patients you see with watery eyes. It's so common in the hospital eye service, not just in oculoplastic clinics. We see it all the time. If you ever do a general clinic or an A&E or whatever, people come to us with patients with watery eyes. I suspect it's just as common in the community. I don't know. I don't have like an incidence or a prevalence or that type of data, but it's an incredibly common problem. And one of our previous fellows, Chris Schultz, wrote this paper looking at quality of life in watery eye patients. And really, if in your mind, to simplify things, if you just keep the 5 causes of watery eyes, those 5 things at the bottom. So the sort of one that we quite like is tear flow obstruction, outflow obstruction. So if you've got punctal stenosis, or if you've got some sort of block in the canaliculus, or some sort of block in the nasolacrimal duct, we quite like that because it's surgically amenable. So we know we can do something surgically about it. Eyelid laxity is another one. That's slightly more debatable in terms of the efficacy of treatment. But if you have a very lax lower lid, if it's frankly ectropic, then that's definitely going to cause a watery eye. So that kind of goes hand in hand with eyelid malposition. And then things like tear film instability and lacrimal hypersecretion. When we do the Q&A after, I'll be interested to know about what community optometrists do with these patients. I mean, they don't make their way into our clinic that much. The sort of dry eye, evaporative eye, dry eye, and the sort of the hypersecretion patients. I think they just never quite get that far. So I probably don't treat that many of those. I probably treat way more of the tear flow obstruction, and then the eyelid malposition and the lax eyelids. That's way more of our clinical work than the sort of dry eye patients. So really, for me, like if you're assessing a patient with a watery eye, the history is the main thing. So when you sit there and just chat to the patient for a few minutes, you can almost always get an idea of what the problem is, or if you're going to be likely to be able to solve the problem. So the first thing I always say is all the time, if somebody wakes up with a watery eye from the moment they wake until the moment they go to sleep, and then they wake in the nighttime to go to the loo and the eyelids stuck together, then that's like a sort of, you can tell there's going to be an issue underneath there. So whether it's a nasolacrimal duct obstruction or something like that, those patients have got an almost constantly watery eye. Patients who get a much more sort of situational watery eye, so when they're out on the downs or on the seafront or whatever, and then the wind's blowing, and then they get a watery eye, then those ones tend to be more ocular surface sort of problems, but they can be contributed to by, for example, like punctal stenosis. So if they're not getting enough tears out of the eye, then sometimes they can be sort of contributed to by that sort of problem. The other thing is where the tears run. So if the tears are predominantly medial, then it may sort of suggest that there's an outflow obstruction. If they're more lateral, then that can be contributed to by a condition called lateral wicking. So you will have seen these patients, often men like me, with quite heavy brows, and if the eyelids hang down laterally, then sometimes the lateral overhang of skin, so the dermatochalasis, can wick tears away laterally. So it's interesting, if you look at those patients, you'll see them in the clinic for sure. You know, patients who've got like almost like a bit of maceration of the skin at the lateral canthus. It's definitely a thing. And sometimes we'll offer those patients a blepharoplasty. So if you remove some of the upper lid skin, then you can sometimes get rid of that lateral wicking. I normally ask one of the other questions I really want to know, and it's a really good question for primary care, so in the community, is to say, you know, what impact is it having on your daily life? Because if it's only like a very minor thing and they're only having to dab that eye occasionally, then the reality is that you're probably not going to offer them an operation, so they probably don't need to come to the eye clinic. But if it's completely ruining their life and they've got social embarrassment and people are asking them, you know, why they're crying all the time, then that's a totally different thing. So you're probably going to be more likely to offer them a surgical intervention. And for me, the treatment should always be proportional to the problem. So if it's a really big problem, then you probably have got to go ahead to do an operation on that person, or you can certainly offer them an operation. But if it's not a big issue, then frankly, you're out of your mind if you're going to be wanting to operate on somebody like that, because you may not be able to match their expectations. So expectations management is a massive thing. And then the other thing is whether they've had previous surgery. So particularly like lower blepharoplasty, something that's pulled the lower lid away from the globe, nasal surgery, traumas, facial paralysis, facial nerve paralysis, and then skin conditions as well, and recurrent infections. So skin conditions like rosacea, people who tend to get sort of fairly red, inflamed skin in the mid face, those patients can sometimes get, you know, blepharitis, meibomian gland dysfunction, and dry eye, and that can contribute as well. And then the only other thing I was going to say is, you know, from a webinar, you might pick up one or two tips. I just tend to check there's no like blood in the tears, because that's something which you probably wouldn't want to miss. And I think in optometry land, you just don't really want to miss bad things. I think you want to sort of know how to refer the common things and know what to do and know what's going to happen with them. And also you don't want to miss worrying things. So hemolacrima is something which you come across a few times a year, and it's worth just asking them, because some of those patients, and I'll just address that straight away because that's something which you probably ask immediately. Some of those patients will have an underlying malignancy, but actually most of them tend to be just mucocele, so they tend to be a nasolacrimal duct obstruction. They've probably got an inflamed lacrimal sac, and so then you get a bit of blood in the tears. Some of them have got subtarsal things, so if you flip the lid, they might have like a little vascular lesion that bleeds. And only a small percentage will have a malignancy, but they definitely need to be checked out. And you know, you basically need to rule out all of the bad things before you call it just a plain sort of mucocele, which is obviously something which can be dealt with surgery. You may see these in practice as well. So it's so common, you know, congenital nasolacrimal duct obstruction is a really common problem. We see an awful lot of this in sort of secondary care, tertiary care. The key thing is, and I'm sure you know this already, but most of these get better by themselves. So almost all of these will kind of just go away by the first or second year of life. Just as the facial skeleton expands, the duct may open, and then the watery eye and the sort of gunkiness goes away. But typically, the parents get quite distressed by it because the eye's watering all the time. They've got loads of gunk around their tears, around the lashes, and they may need lots of courses of chloromphenical. And sometimes they get fed up, and then you have to do something, which is normally a short general anesthetic, and we put a little wire down the tear duct. So it's called a Bowman probe, which is probably about that long. And we pass that down the tear duct and just try and push it through the valve of Hasner, so the very bottom valve in the nasolacrimal duct. And then that will often work. So in about 80–90% of the patients, that will work. I would say most of the patients that require that would be done by pediatric ophthalmology. So if you've got, because they have easy access to lists. So if you have these patients in the community, so young kids, you know, 6 months old, a year old, refer them to the pediatric ophthalmologist. So that'll be Vicky Dave in Eastbourne, or in Brighton, it'd be Dominic Heath or Victoria Barrett, because they all tend to do that first. They've got more access to lists. if that doesn't work, then we tend to get involved and we would do a DCR or stent or something like that. So, but most will go away. So you can reassure the parents that with a bit of massage around the medial canthus, often that will go away and they don't need to do anything about it. In terms of reflex epiphany, this is something I suspect you see a lot of in the community. I think you just need to be sure you're not missing something else. So if it is dry eye, I'm sure you all do, you all put fluorescein on the eye and check for dry eye and look for tear film breakup time. But just check underneath the lid, make sure you're not missing something, or a lash that's poking in against the eyeball, or a foreign body or something which is just irritating, and then they're getting lots of reflex watering. As I said before, almost always these patients get much worse symptoms when they're out and about, and you will have heard this story hundreds of times. But they're on the seafront, they're not wearing glasses or something, and they get lots of cold air into the eye, and then they hypersecrete. I mean, even I get that, and I don't think I've got particularly dry eyes, but I definitely get that when I'm cycling. And normally you can just treat them with treating the underlying cause. So if you give them eye drops, it might improve it a bit. And obviously, if they've got allergic component, you could try some anti-inflammatory or antihistamine drops. And then if they've got lashes, you can epilate them or send them in for electrolysis if that's a problem. And then this is a bit of a boring bit, I'm afraid. So the aqueous deficiency, tear film instability. So yeah, just check the tear film breakup time. I don't know if you do Schirmer's test in community. We don't do loads of it in the hospital now. I tend to rely more on the tear film breakup time. But if we think someone might have, for example, Sjogren's syndrome, then often we'll do a Schirmer's test. And these patients can be treated in the normal way you treat a dry eye patient, so lubricants and then heat masks and all that sort of stuff. And some of them will improve and some of them won't. And if there is an outflow obstruction component, then they might need to come and see us. And this is something to be aware of, which we probably see more. I see way more in my sort of practice over in Brighton, which is patients who've had seventh nerve paralysis. So the seventh nerve, I'm sure you know, but so the seventh nerve powers all of the muscles of facial expression, so your orbicularis and all of the muscles in your face. And if they have for example, a Bell's palsy, you get aberrant regeneration. So the nerve kind of miswires, and then when you open your mouth or you chew or laugh, then you can get crocodile tears, so you can get a watery eye. We see quite a lot of this because it's common. We see these patients who've had surgery, so patients who've got parotid tumors and they have lacrimal gland, facial nerve injury. They will get crocodile tears, and we typically would either treat them conservatively, so we wouldn't give them anything. We'd probably just sort of try and take them away from surgery, or if they're very symptomatic, we'd try Botox into the lacrimal gland, and that can be really effective. And colleagues in East Grinstead have published on that, and it can be a useful way of treating them. So just broadly in terms of the assessment, I think I always try and, for oculoplastics, I typed in into Google, I typed in nice or bright optometry room, and that one came up. I'm sure all your practices look at that. It's definitely nicer than where I work. So have a look in good light. So you want the patient in lots of bright light. I hardly ever do my plastics clinic in the dark unless I happen to see someone who's, not a plastics clinic, a patient. So have a soft look, just look at the face, have a look at the skin, the periocular skin, check if, they've got any sun damage. A lot of these patients, you get like a cicatricial, that's a scarring ectropion. So perhaps they spend a lot of time in the sun. They may have other bits of actinic changes on their scalp and so on. Have a look if they've got a negative vector. So negative vector is something that confused me kind of early in my career, and it's something that I look for a lot now because I'm much more surgical now. So the negative vector is when your globe is more protuberant than your cheek. So your globe sits before your cheek. And those sorts of patients may have a slight bit of lower lid retraction, especially in the patients who've got lots of sun damage on their face. And then evert the lid as well. Have a look at the lacrimal gland. You just want to check you're not missing any masses there. Have a look at the conjunctiva as well for pterygia and pingueculum and all that sort of stuff. And then critically have a look at the punctum. So it's something in practice you can do is just to look at the puncti, check that they look normal. I'll show you some pictures in a bit just to sort of show you what normal looks like and what abnormal looks like. And then I don't know, I'd be curious to know if people syringe in practice. We do it obviously all the time. It's a pretty straightforward thing to do, but the technique's kind of fairly, I guess you have to be careful. You can't kind of have a go. You probably need to be trained in it before you did it, because you can potentially damage the canaliculi. The fluorescein dye disappearance test is quite popular with some people. So Mike Werner Eastbourne uses this a bit, I think. So if you get 2% fluorescein, you just put it in the fornix. You might want to do it at the start of your consultation. So if the patients come, I know MEX doesn't exist anymore, but if the patient happens to say they've got a watery eye and you've done all of your refraction and so on, if you put a 2% fluorescein into the fornix and just see what the level is like, and then measure again at 5 minutes, and if it's all gone, then it's unlikely to be an outflow obstruction. So it might be more like a reflex watering or a dry problem or whatever. But if it's high initially and then it all goes away, you can pretty much reassure yourself that the drainage is good through the system. So you might not need to syringe them. And compare eyes, because nasolacrimal duct obstruction isn't always bilateral. So about 3/4 would be unilateral. So if you compare the two, and has got a higher meniscus than the other, then you could probably sort of have a fairly good guess at the cause of it. So I always sort of preach, it's probably quite boring to hear, but I always preach this kind of like outside in thing. So always like try and zone in from the outside in. I think as eye doctors and optometrists, you always look straight at the eye. And that's natural because that's what we're most comfortable with. But if you kind of zoom out and look at the face, I can't ask questions on here. I normally try and engage people by asking questions. But if you look at this lady's right eye, you can see she's got a slightly S-shaped lid. So if you compare, most eyes are kind of like almond eyes or whatever, that's what people want anyway. If you look at the left, it looks relatively almond shaped. And if you look at the right, it's got a S-shaped lid. And that's really characteristic for patients with lacrimal gland enlargement. So that could be anything. So it could just be that the lacrimal gland's prolapsed. It could be that the lacrimal gland's inflamed. It could be there's a tumor in the lacrimal gland. Or it could be that you've got an infection like a dacryoadenitis or something. The cause of lacrimal gland enlargement is like unbelievably large. It more or less encompasses all of the sort of pathologies you can get in the body. But you will see it occasionally. We certainly see it in the A&E sort of probably once a month in Brighton, patients with some sort of lacrimal gland enlargement. It may not contribute to the watery eye, but it's going to feature in your assessment. I mentioned before about the tear wicking thing. So this is definitely a phenomenon. And what they tend to experience, the picture on the bottom right there, so the sort of F on that picture, this is published by Dinesh Selva, who some of you may have heard of. So the bottom right is sort of quite typical. So when the tears get wicked laterally, they tend to macerate the skin, and the skin can break down, and you get this sort of chronic irritation around the lateral acanthus. And you, especially in patients who've spent more years on the planet than us, I guess, you will definitely see this overhang, and there will be a little bit of irritation, and it can be a real problem sometimes, and it can definitely contribute. So if that's definitely an issue for the patient, I would sometimes offer them a blepharoplasty if that's what they wanted. If it's a big enough problem, I would suggest either lifting the brow a bit and trimming some skin laterally, and that will solve the problem often. And then evert the lid as well. If you want to look at as I mentioned before, the lacrimal gland's got two lobes, the orbital lobe, which normally you can't palpate unless there's a pathology there, and then the palpebral lobe, and you will see sometimes like little cysts in the palpebral lobe, which is called a dacriops. And if you just lift the lid and ask the patient to look down and in, you'll sometimes see a little cyst in the lacrimal gland, or you'll see the palpebral lobe itself. And it's just useful to have that in your armory as part of the sort of examination of a patient with who's complaining of epiphora. And take a look at the skin as well. Hand in hand, like I saw a patient this morning in Brighton who had a really watery eye. It's like profuse, constant. She's a young lady, and she's got really bad damage to the skin around the eye. So affecting not only her quality of life, because her tear film is high, she can't see through it properly. Her eye's watering all the time, and then the skin starting to break down around her eye. And then you can see why that would be a problem for a patient. And the issue there is you end up in this sort of downward sort of spiral, this negative spiral where the eye waters, then the skin gets irritated, and then the eye waters more, and then you get more skin irritation, and then you get a nectropion. So the skin irritation often will turn the eyelid away from the globe. And then because the punctum's not facing in against the globe, and you get more watering, and then the more watering you get, the skin gets worse and worse and worse. And I've certainly had quite a few of these patients lately where the skin condition is getting just terrible, and you're trying to manage the patient, and then you're trying to sort of balance when you would operate. So sometimes what I will do is I'll tell them to put some Vaseline on the skin and use that as almost like a sort of barrier to the tears, because the tears themselves can get quite toxic to the skin. So if you put a Vaseline on and maybe some Maxitrol ointment or something like that, just to try and reduce the inflammation. sometimes then the ectropion improves, and then you can deal with the watery eye and or the residual lid position. So the skin is important because it kind of gives you a clue as to how bad of an issue it is. And then have a look at laxity as well. Again, something you can do in practice. If you, I don't really grade it, I have to be honest, but if you wanted to be very, assiduous about your assessment of a patient, you could grade it. I normally just distract the lower lid away from the globe, and I look for sort of horizontal laxity, so how mobile the eyelid is horizontally and how mobile it is vertically as well. And then you can grade it. So usually I sort of say, if the punctum is meeting the limbus, then that would be sort of moderate, and then if it's reaching the pupil, then that would be severe. And you kind of get a feeling for how lax the lid is as well with a sort of snapback test. So I don't know if people do this, or you may have seen it. Sometimes, particularly in patients, in their sort of 70s, 80s, 90s, they will have lid laxity for sure. If you pull the lid away from the globe and just distract it, sometimes you'll get a sensation that the lid's just not returning back to the globe. And these patients can sometimes benefit from lid tightening. So if you just distract it, if you sort of pinch it almost just very gently and pull the lid away, sometimes it will sit there for 1, 2, or 3 seconds, and eventually it'll return to its resting position, but sometimes not. And in those patients, sometimes you can just tighten the lid horizontally. So one of my old colleagues in Newcastle, Eric Barnes, published on this. And if you tighten the lid surgically, so that'd be an operation called the lateral tarsal strip usually, about half to 2/3 of patients will get an improvement in their watering. So it's worth just being aware of it as a phenomenon. Again, this is probably not going to sort of form lots of your patients in primary care, but it's definitely worth being aware of. And then kind of a little bit with that, redundant tissue, excess tissue goes conjunctival chalasis. I'd be curious to know if you see this as well in primary care, or if you ever come across it. But if you look carefully, you will see it. So some patients have just got these extra redundant folds of conjunctiva, and the theory is that with the extra bits of conjunctiva, they tend to sort of ruck up onto the lid margin, and they can stop your tears going into the fornix, and they can stop them draining. So sometimes they'll spill over onto the cheek. And sometimes you see it with allergies. So sometimes you notice there's a few papillae on the tarsal conjunctiva. The eyes are a bit red and angry. So you can try topical steroids, and equally you can try surgery. I have to say, like in my sort of hands or experience, I haven't had massive success with the surgery. I think you're kind of treating a problem, but I've never had this sort of miraculous event where the patient has their conjunctival chalasis removed, and we normally remove it either surgically with cautery, or remove it surgically and stitch it or cauterize it. But I've never found it to be that satisfactory. But it definitely is something that exists in patients. Yeah, and take a look at the puncti as well. So this was a patient that we operated on in Eastbourne. So he'd had a very big SCC on the medial acanthus, but we put a big graft on. So the SCC was probably about the size of a, I don't know, 250p pieces. So it needed a really wide excision. Puncti were preserved, but when we put a graft on, which you can see, so the graft is the bit that's sort of on the side of the nose, it's kind of pulled the lower lid away from the eyeball. And you can see the inferior punctum is about 0.5 centimeter away from the eyeball. So you can see why somebody like that might be having a watery eye. So that's the first thing, is to look at whether the punctum's facing into the eyeball. So is it facing into the tear lake? And when you look at punctal stenosis, you can even grade it. I mean, I have to say I don't do this. I don't write this in the notes. But A on here would be a normal punctum. So that's probably about right. And then E is clearly punctal stenosis. And then sometimes you can get a completely, you have like a really severe conjunctivitis, scars over. You may see it in glaucoma patients who are taking lots of meds, and you can get various different shapes. But these patients in general will benefit from a punctoplasty. And then, yeah, curiously as well, you can get absence of the punctum. So in some kids, if you see an infant with a very watery eye, just have a quick look and see if you can see the punctum, because it may not even be there. And then equally, you can get sort of double, so you can get sort of duplication of the punctum, and some will be a true punctum, and the other one won't be, and the other one will just be a blind ending tract. So it's not really helping. And we see these patients every so often. In fact, I saw like a sort of a duplication about 3 months ago in Eastbourne. So they do pop up every now and again. And then I mentioned about the sort of punctal eversion. So punctal eversion is something which is quite subtle. You have to really look for it, and often it's only 1 millimeter or so, and it will often go with a bit of chronicity. So you'll see a bit of chronic changes on the lower lid. The punctum might be a bit stenosed, and it might be a bit turned out. Often they kind of go hand in hand. So punctal stenosis, a bit of eversion, and typically the skin will be a bit affected as well. So they've got a bit of a sort of cicatricial component to it. For some patients with punctal stenosis, you can try plugs. I know that in Eastbourne, they use perforated punctal plugs quite a lot. So perforated punctal plugs, you basically push into the punctum, into the canaliculus, and it sort of stents open the tear duct, stents open the canaliculus. So it's like putting a stent into something. I find these quite tricky to put in, to be honest with you, and I'm not sure how well they work, but there is a bit of published evidence they can be effective. I tend to do a punctoplasty personally. So a punctoplasty is an operation where you just widen the punctum, and we normally do this by cutting straight down into the ampulla and then along, and then you join the two bits up, and you end up with a sort of elongated punctum like you see on the right-hand side. If a patient's got punctal stenosis and they say, oh, okay, if I'm referred, what's the chances of improving it? I would normally say about half to 2/3, which isn't amazing. Maybe if you're lucky, 3/4. But I would say it is really, in reality, it is like that. So if you do surgery, I would say, well, look, the surgery is fine. It's very straightforward. It's very low risk. But there is a chance you come back and you're deeply disappointed by the outcome of the operation. But if someone's got true punctal stenosis and they've got no outflow obstruction other, distal to that, so nothing in the nasolacrimal duct, they may well benefit from this. And it's certainly worth doing it because it's such a low risk procedure. These patients crop up every now and again as well. So canaliculitis is the sort of thing that catches people out for months on end. These are both patients I've recently seen in Brighton who've had kind of a chronic discharge from the eye. Often they've got a lump around the punctum. I would say most of the time people get caught out because they think it's a chalazion. So they often get referred and say this patient's had a chalazion for like 1-2 years. They got lots of discharge. They're really irritated by it. And if you look, they've often got this really characteristic swelling around the punctum. It can be inferior or superior. They may have had punctal plugs before, so just be aware. Like ask them, have you been treated for dry eye before? Have you had some punctal plugs put in? Because some punctal plugs go all the way down into the tear duct, all the way into the canaliculus, and they sit there and you can't see them. So you might not necessarily notice on examination. And these patients can only really be treated with what you call a canaliculotomy. So you have to just dilate the tear duct, so dilate the punctum, open it, and then you remove millions and millions and millions of these little crystals. So you can see there on the picture on the right, there's a sort of little whitish thing, and they just keep on coming. So it's almost like it's so improbable. I can't ever quite understand where they all come from, but they just keep on coming, and you can just keep pushing them out of the punctum. And most of the time, that will sort the problem. It's typically caused by a bacteria called actinomyces, and actinomyces can be responsive to chloramphenicol. So if you were in the community and you thought like, okay, the patient's got canaliculitis, it's reasonable to give them some chloramphenicol drops. And sometimes you will see that. So they've been given some chloramphenicol drops, it's got better, it's got worse, it's got better. And they have this kind of cyclical thing by the time they get to hospital. So you're kind of getting there. What's the time now? 8:35. Another 10 minutes max. So you've got to bear the watery eye talk. So nasolacrimal duct obstruction is really common. We see a lot of this in hospital. It probably forms like most of my surgical workload for watery eye patients. You will sometimes see patients with a mucus seal. So if you just press gently on the inner corner, the mucus will come back out of the punctum. It's kind of reassuring actually, because then you're dealing with probably just primary acquired nasolacrimal duct obstruction, so PAN, primary acquired nasolacrimal duct obstruction, which usually needs a DCR. So DCR is a dacryocysteal rhinostomy. Some people do it through the skin, so they'll do a skin incision just sort of medial to the medial canthus. I typically do it endoscopically. So there's kind of been this shift over the past 5 or 10 years for people to do endoscopic DCR rather than external. So it's probably just, I would kind of equate it a bit like ECCE to phaco. So when people went from extracapsular cataract extraction to phaco, there was this sort of shift in the way people are doing it. And I think now there's a much more of a shift toward endoscopic. And the advantage is that you don't have a scar. So often patients don't really want a scar unless they have to. And also it's fairly quick operations. So, but it does require general anesthetic. It can be done under local anesthetic with sedation, but it's not pleasant. So most patients need about a 45-minute general anesthetic. That means going to sleep. And it has the same success rate as an external DCR. So, but it's not nothing. So again, it goes back to the kind of expectations of the patient and making sure that they're kind of aware of what the surgery is, because if they know what you're doing, which is essentially removing bone, removing your maxillary bone and some of your lacrimal bone, they might decide not to do that. So it's really important that they kind of know what's coming. Quick video of endoscopic DCR. So for endoscopic DCR, this is surgical video in case you don't want to watch it. I know some people don't like watching it, but this is in the left nostril. So it's a very tight nasal space. So this is called the turbinate. So the little thing that you can see sort of hanging down there is the turbinate. Then we have to incise, make a cut on the lateral wall of the nose. So we remove some of the mucosa, so the lining of the nose, and we kind of join it all up. This is a sort of real life video, if you know what I mean. It's a very tight nasal space in a young individual, so it's not an easy operation. I think I showed this on some previous teaching I'm doing. So we raise a little flap of tissue up from the inside of the nose, and then we got these little bone removal devices called rongeurs. The only reason I'm showing you this actually is because so say if you do have a patient who's going to have a DCR, you kind of have an understanding of what it is. So it is, you know, it's definitely sort of surgery. It's not just like a little punctoplasty, because we're removing bits of bone. So we use these little rongeurs to remove bone. And then sometimes it gets really awkward because the angle's difficult. And then once we've removed enough bone, we'll often use a drill just to remove a bit more bone at the top. I'll skip it on a bit because you probably don't want to. Oops, hang on a sec. So we use a little burr to remove a bit more bone from the top of the where the lacrimal sac is, and then we open the lacrimal sac with a little knife. So that's going into the lacrimal sac, but from inside the nose. So that's usually how I would typically do a DCR. I personally just find it easy, and that's the way I was trained. So, but some places it will only offer external, but I think if you can offer both, it's kind of advantageous. So that's a DCR from inside the nose. It's quite a gruesome operation. And then just briefly about functional epiphora. So there is this group of patients. Part of the reason I'm telling you this is because you may get letters back from someone like me or Mike Wern or whoever it is, and we would say the patient's got a functional block. Like, what does that mean? Well, basically, a functional block means that when you syringe through the tear duct system, it's all patent. So there's no block. There's nothing coming back out onto the ocular surface. And it's kind of a curious thing. So the patient's got lots of epiphora, and then if you investigate them with something called a DCG or which is a dacryocystogram or a dacryosintogram, they have like a slow flow down. So if you're pushing water down, it all goes down. But if you look at the natural flow of tears, then it would be quite slow. And these patients can be offered a DCR, so dacryocystorhinostomy, but in my experience, they don't tend to get the same improvement in the symptoms as you might do for someone who's got definite nasolacrimal duct obstruction and a very watery eye. And if you do something, we sometimes do a test. So again, this is just for your knowledge and your kind of understanding of what we do. Sometimes if we're a little bit unsure about the cause of the watery eye, we do a dacryocystogram. So you have a dye that's injected into the canaliculus here, goes into the lacrimal sac. So the lacrimal sac is the sort of dark bit on the top left as you're looking at it, and it goes down the nasolacrimal duct and then it exits into the nose. And we will look for sort of tortuosity, stenosis. Sometimes you can get like little outpouchings from the duct. That's called a diverticulum. And that's just useful. If we're going to do an operation, we kind of want to know there's definitely a blockage there. And then equally, a dacryosintogram, so dacryosintogram DSG, you might see in our letters sometimes. So we put a bit of radioactive tracer on the surface of your eye, and you sit in front of a camera, and they look at how the tracer goes down the nasolacrimal duct. And on the right-hand side, so as you look at it, the left, there's good flow of tracer down to the nose. On the right, as you look at the left side of the patient, there's no flow really down to the nasolacrimal duct. So that patient might have a functional block, and they might benefit from a DCR procedure. I put a star on there. It's not totally clear. So on that picture on the right-hand side, where the star is, the trace is not going down into the tear duct very well. And then I think lastly, Lester-Jones tubes. So just so you're aware, Lester-Jones tubes really for us is like a last-ditch attempt. So if a patient's got a persistent watery eye despite having had a DCR, and perhaps they've got like a blockage in the canalicular system, then we might offer them something called a Lester-Jones tube. So Lester-Jones tube is like a little Pyrex tube, and it goes through the inner corner. So it's from the medial acanthus with just anterior to the plica. So we take a bit of the caruncle off and then push that through into the nose. and then that sits in the inner canthus. You may see them in practice. It's a deeply dissatisfying operation because only about half of patients will have a long-term survival of the tube. So if they say like, what's the chance of this working long-term? It's about 50%. So we kind of really undersell it. And then some patients love it. I've got several patients who you just have to have them flushed every so often. But they solve the watery eye problem. But some patients it's a nightmare because either they're very uncomfortable, even they may get double vision, and they just cannot tolerate them. So if you ever see these, we do them occasionally, and it's sort of really for us, it's once all else has failed, then we'll offer a patient a Lester Jones tube. That's kind of the end stage of watery eye treatment. So I think that's it. So I didn't want to go on too long. It's about 40 minutes. I think that's what I suggested to Ian. So there we go.
Thank you very much, Huw. That was really interesting. That was so. I appreciate that and your time in you've taken to put that together. We do have some questions for you, if that's okay.
Yeah, of course. Yeah.
Someone has written, so 50% of my patients have symptoms. Is that true of watery eye? That 50%, only 50%? I thought more than that.
What's that now? Is that 50% of the patients that they're seeing?
50% of his patients that this person sees has symptoms of watery eyes.
I could well believe it. I mean, it's such a common problem. I mean, we've got I think our waiting list to see patients routinely in the eye hospital in Brighton now is I think it's about 45 weeks or something like that. And probably a large proportion of those are watery eyes. And until you've seen them and diagnosed them, you don't really know what the cause is. I would guess that's probably a fair representation. I don't work in the community, but I think we see a lot of it. And so I suspect in the general community it's a very common problem.
Yeah. And somebody's put very common, especially in the elderly. I don't know which slide that was referring to, but it's probably more common in the elderly, watery eyes, is it? I would have thought.
Yeah, it is. Yeah. So definitely the sort of common things like punctal stenosis, like nasal lacrimal duct obstruction is much more common in elderly. And also they tend to get more of the sort of dry eye, so the aqueous deficiencies and the meibomian gland issue than youngsters. So it probably has a sort of bimodal thing. So it's we see a fair number of youngsters with it. So, infants or like newborns, and then later on in life. And then you do get a few people, we do DCRs on people who are like 20, 30 occasionally. They may have had a watery eye when they were very young, and then it's sort of settled down, and then it's become more of an issue in their 20s and 30s, but probably more at the start of life and then the end of life.
Yeah. So here's an interesting one. So with fluorescein tear breakup time, what do you class as dry eye?
I think I'm sure there is a particular grading. I think if the tear film is stable for 10 seconds, then I would sort of think that to be okay. So anything less than that might be suggestive of a dry eye, or some sort of issue with the tear film, whether it's a sort of lipid issue, so whether it's a stability problem or an aqueous problem or whatever. But I would normally expect the tear film to last definitely over 5, but probably 10 seconds. I'm not a dry eye specialist, so I'm a
I think next time I'm with you on a Wednesday, I think I'm going to test myself, put fluorescein in and get you to test it and see. I think I've probably suffered with dry eyes a little bit.
Probably, just about everyone does, don't they?
So how is Sjögren's syndrome diagnosed? Is it simply a dry eye with a dry mouth or other mucous membranes?
Yeah, so Sjögren's syndrome is a condition, so it's an autoimmune condition directed at your sort of exocrine glands, so typically lacrimal gland, but then also your buccal mucosa as well, so the glands that secrete saliva. And normally we diagnose it, so primarily it's a history thing, so the patient will often have a concurrent dry mouth. I would then usually do, offer them a buccal mucosal biopsy, so sometimes a biopsy, but also bloods as well. So we send them for antibodies, so ANA, and then particularly antibodies called anti-Ro and anti-LAR antibodies. So they typically need blood investigations and sometimes a biopsy as well. Sorry, that's a mistake actually. So buccal mucosal biopsy is for mucous membrane pemphigoid. So usually it's diagnosed off bloods. So anti-nuclear antibodies and anti-Ro and anti-LAR.
Is there like a family prevalence? So if it's in the family, are you a lot more likely to have it at all, or?
I don't know. Not sure. It's a good question. It's a very reasonable question. I don't know.
Sorry, that was my question. Sorry.
No, it's a good question. I don't think so. I think it's like a sort of primary autoimmune condition. I don't think it's something that goes through family, but there are like groups of, so like Sjogren's syndrome groups. There's definitely one in Brighton because I've given a talk at that before. There's normally like local Sjogren groups and stuff because it's such a problem, you know. It's definitely it's one of these things that has a massive quality of life implications for people.
Yeah. Cool. Thank you very much. So, patient suffers from occasional watery eyes, obviously. In this case, surgery is not an option. What would be suggested? Does diet have any impact?
No, not that I'm aware of. I don't think there's any sort of dietary things, but sometimes like omega and so on has been suggested that, you know, that can be helpful for the tear film. So I don't think so. There's nothing that's kind of overwhelming in evidence. I think for me, like as a doctor, you kind of want to be sure that you're giving people like evidence-based information or treatment. So I don't think there's anything sort of dietary. With very like, you know, so with someone who doesn't want surgery, I would try and treat them symptomatically normally with eye drops, I guess. It can be helpful. It's certainly worth trying. You know, if you think they might have a slightly dry eye, there's no harm in giving someone some dry eye drops. You're not going to harm them by doing that. And then maybe trying things like heat pads, you know, like the sort of Taya eye bag or whatever, that type of thing. That can sometimes help as well because it improves the meibomian glands. But non-surgically, there isn't a massive amount you can do. There isn't sort of like this sort of magic bullet that can just solve it all without surgery. Which is why I said at the start, you know, for me, like the main thing is like the surgically amenable epiphora, because I kind of want to know straight away whether I'm going to be offering someone an operation, and then and as soon as I kind of have that in my mind, I want to know it's definitely proportional to their issue. So for those patients stuck in the acute, there's no sort of like, you know, thing which is going to solve their problem if it's kind of intermittent, which is an issue. But I think all of those things I suggested, like drops and heat pads and so on, can be helpful.
So, thinking from my glaucoma clinics and with dry eyes, do you have a preferred choice of dry eye drop you would recommend?
Well, I have to say no. Like the problem is that, you know, the reps come around. Obviously there's lots of different. There's loads and loads and loads of dry eye drops, and I find that they have to be careful, don't you? Like recommending things, but
Yeah,
I think Taylor's Duo seems to be really well. These patients seem to quite like that as an eye drop. It seems to be well tolerated.
that's something I recommend because it's preservative free.
Yeah, exactly. It's preservative free, and I think it also has some sort of lipid component to it as well. I might be totally wrong there, but the patients certainly seem to tolerate it well, and so I often do recommend that. But you have to be so careful because, like, you know, you end up kind of and often it depends where you work and if it's on formulary. So in Eastbourne, we tend to prescribe a lot of Taylors because it's on formulary. In Brighton, we often went through a phase of prescribing loads of Hylofor because it's on the formulary, and we can do that.
Yeah.
And it often just changes depending on what the local sort of pharmaceutical regulations are and what they want to have on the formula in the hospital. So for us as clinicians in the hospital, it really depends on what's freely available. Taylor seems to be well tolerated, and I don't mind using it.
Do you want to stop sharing your screen? I've just noticed where.
Yeah, sure. Yeah, of course.
Sorry. So would you offer any treatment for conjunctival retention cysts?
Yeah, I do. Yeah, in the clinic, it's quite a straightforward thing to do. So if you just got proximethicane, you can just like bend a little green needle and just kind of like hook them out of it's like sort of, you can kind of just like make a little nick in the conj and just pull them out. If you think that's the cause of the watery eye, I tend to find that the ones that cause problems are the ones that are in the upper lids and are kind of like breaking through the conjunctiva. And definitely I've seen a few patients over the years when they've got this sort of like, you can see it's almost breached through the conj and you've got this little sort of rough bit on the conjunctiva, which is the retention cyst. And so those ones can be sorted out. Yeah, you can just kind of,
You can sort of.
yeah.
Cool. Is there a minimum and maximum age for fitting a Lester Jones tube?
Definitely not a sort of maximum age. I think from a minimum age, you wouldn't be putting it in a very young child because the likelihood of them tolerating it would be very low. So I've never put one in a child personally. I'm sure people will have done. Usually it's sort of patients who've been through lots of surgery in the past. So, you know, they may have had one or two failed DCRs. They're aged 50, they might still be working. you know, they don't really want to have a watery eye. It's embarrassing. So it's people who are getting really desperate. So I would say children are very, I've never done that personally. And the maximum age is just really, if the patient's fit, they can have the operation. You know, if they're 90 and their watery eyes ruining their life, then there's no reason they can't.
Cool. What is your opinion of the heated eye wand for meibomian gland dysfunction treatment?
That's a good question, and I've never heard of the heated eye
I
ones.
don't
So
know. I see that.
if Melina could educate us, then that would be fantastic. That's not something. That's not something. If Melina could just post on there and tell me what the heated eye wand is, then that would be quite useful because then I could potentially recommend it.
So, not a question, but I work in Seaford, and everyone complains of watery eyes.
It's
That's
quite
probably
windy in
isn't
Seaford,
it?
isn't it? On the seafront there, it's quite a windy place. It's get exceptionally windy on Seaford Parkrun on a Saturday morning.
Next one is what is your go-to dry eye drop? I think you've mentioned that really with the
Yeah,
full.
I tend to suggest Taylor's Duo. Just, mainly when I'm at Eastbourne, Taylor's Duo. I tend
Yeah.
to suggest.
So with babies with blocked tear ducts that require surgery, you mentioned a fine wire. How is this inserted? Is it via punctum? How do you negotiate the wire around the anatomy? That's interesting.
Yeah, normally what you do is if they've got a punctum, so you can, like I said before, sometimes you end up with congenital absence of the punctum. If they've got a punctum, you put it vertically in and then horizontally until it reaches bone. So that would normally be the lacrimal sac. Then you have to sort of rotate the wire. So it's called a Bowman probe. It's kind of like semi-rigid, so you can bend it, but it holds its own shape by itself. So you push it along horizontally until it reaches bone, which would be lacrimal sac, and then you kind of bring it vertically and push it slightly posteriorly, and it should just find its way down the nasolacrimal duct. And then it should slide down freely. And then if you just gently push it down, it just pops out of the bottom of the duct. And if you look in the nose with an endoscope, you'll see it just sitting there. And then you know you've done it. It's actually quite difficult. And people used to do it blindly. You know, the sort of classic scenarios, you just sort of push it down and think, oh, yeah, that's about right. That should be fine. That's sorted the problem. But actually, you should be looking in the nose and checking you've done it correctly, because, well, if you haven't, then it's a waste of time. And yes, if you look underneath the inferior turbinate, you can see the valve, so the valve of Hasner, and you can see it popping out underneath.
I'm going to be quite quick because my computer keeps flashing up that it wants to do an update. And as you probably know from working at Trust You, that it says that, and then all of a sudden it shuts down,
Down.
update without warning. Would Hycosan be an option to recommend in glaucoma patients as it's preservative free also?
Yeah, that's definitely fine. Yeah, I think I generally suggest, this isn't really evidence based, but if you're using an eye drop like more than 4 times a day, a lubricant, probably make it preservative free, especially if they're already on, like, you know, latanoprost or Lumigan or something, whatever. If they're already on glaucoma meds, then I'd definitely avoid more preservative. Because, you know, there's Ganfort patients, their eyes are just screaming for mercy, aren't they? Like,
Yeah.
so if they're, yeah, Hycosan would be fine. It's preservative free, isn't it? So anything like that is totally fine.
Cool. I think this is an answer to your question earlier. It's available from Positive, is from Melina,
Oh yeah.
available from Positive Impact by then Peak Club, and does seem to work well instead of the hassle of heating an eye bag and bullying the eyelids.
Burning the eyelids, maybe. Yeah, that's interesting. I'll have a read about that. It's not something I've come across. Yeah.
Cool. And the last one, lots of patients talk about duct syringing, but I understand that this is more of a diagnostic procedure than a treatment.
Yeah, so that's why I said at the start, you know, I think a lot of the time our hospital eye service referrals are, you know, can you just sort of, you know, dyno-rod this patient's tear ducts and sort them out. So lacrimal syringing can help sometimes. So if you syringe through and flush it out, some patients will be like, oh yeah, fantastic, that's kind of sorted the problem out. And we do have a handful of patients who come back every 6 months for like some sort of homeopathic flushing of the lacrimal system. But it's diagnostic, yeah. So it's not a treatment, but sometimes it does help. I mean, sometimes I'll say, well, you know, because occasionally if you have to dilate the punctum and then you syringe through, maybe it's the dilatation of the punctum that helps. I don't know. Because sometimes the punctum is so small you can't actually get the lacrimal cannula in. So to get it in, you have to dilate the punctum. So it may be that, but yeah, in my mind, it's a diagnostic thing. So I'm trying to work out if there's some sort of outflow problem further down. Yeah.
Thank you very much. That's all the questions. So thank you everybody for watching tonight, and thank you to Mr. Oliphant for giving up his time to write the talk and present the talk tonight. I will get the certificates out, I'm going to say within 2 weeks, so please don't email me if you haven't had it tomorrow, because the GOC give me 10 working days, so I will get them out to you soon. Please keep an eye on our WhatsApp group, because we've got a really interesting, exciting event coming up. Probably only relevant for people who live locally, because it's going to be a sort of a face-to-face event, but it's going to be interesting, and I will be advertising on that on our WhatsApp group. And Mr. Oliphant hopefully will be there as well as Mr. Kashani, and maybe a couple of the other consultants, so you'll be able to meet them as well. So thank you very much for watching. This webinar I will try and get put up on the website, on our YouTube channel in the next couple of weeks as well. So thank you very much, Mr. Oliphant.
Lovely. Cheers, Ian. Thank you very much. Thanks for having me.
Thank you very much, everyone, for watching. Thank you.
Cheers. Take care.
Bye-bye.
All right.